Fellowship at Harbor-UCLA Medical Center. Dr. Nikolaenko's clinical and research interests center on immunotherapy and hematopoietic stem cell transplantation in patients with lymphoma. She leads several clinical trials evaluating novel agents for the treatment of relapsed or refractory non-Hodgkin's lymphoma. Fluent in Russian, Dr. Nikolaenko holds an active membership with the American Society of Clinical Oncology, the American Society of Hematology, and the American Society for Transplantation and Cellular Therapy. So with that, I will hand it over to you, Dr. Nikolaenko.
Good evening, everybody. I hope you can hear me well. I would like to thank Cancer Support Community for inviting me to present on the topic of immunotherapy in hematologic malignancies. I would like to share my screen. Okay, let me see. Okay, let me see. I'm sorry, guys. Let me just. Okay, are you able to see my screen?
Yes.
And is this in presentation mode, or you can see?
We can see the presentation, but not your notes. So you look all good.
Okay. All right. So today's topic is on advances in immunotherapy for hematologic malignancies. So for today's objectives, I would like to have an overview of immunotherapy, what it is, as well as types and indications of monoclonal antibodies, which are treatments for patients with hematologic malignancies. We're also going to go over CAR T-cell therapy, what it is and how it's made, as well as management for CAR T-cell related side effects, and we'll look into future directions. So for the introduction, so what is the immune system? Immune system is a collection of organs, bone marrow, lymphatic system, immune cells, and also immune molecules such as cytokines and interleukins. All of them together collectively protect our bodies from infection and diseases. Immune system is able to recognize foreign substances and cells and microorganisms, sending an alarm down the immune activation pathway. The activated pathway of immune system enhances this system and arming it to be able to defend our body. Cancer cells can evolve from a healthy cell. A normal human cell can contain some mutations and become cancerous. And in this way, because they're generated or developed from a normal cell, they can evade immune system so that immune system does not recognize a cancer cell as a foreign. Recent advances in medicine with a focus on immunotherapy have provided enhancement of immune system to fight cancer on its own. So what we know is that one type of immune cells called T cells, for example, they enable a highly specific response against a particular target and can eliminate infections and tumor cells. Immunotherapy uses person's immune system to fight disease, such as cancer or hematologic diseases. One way to stimulate our own immune system so that it is able to find and attack cancer cells by using, for example, checkpoint inhibitors, and we will go over what those are. Another way is to artificially produce molecules that resemble immune system components to help enhance immune system function against cancer, monoclonal antibodies. There is a way to tweak immune system to be able to recognize a cancer cell. And that type of therapy is now called CAR T-cell. the type of cancer immunotherapies, what do we have? So for example, monoclonal antibodies, sometimes we call them MABs or MOABs. And these are human-made proteins of immune system. So our bodies make our own immunoglobulins, but when we produce monoclonal antibodies with a specific target to function, these are artificially made. So monoclonal antibody target is a targeted therapy, and it is created to identify specific part of the cell or target specific part of the cell. Other type of immunotherapy are called checkpoint inhibitors. And these particular inhibitors take breaks off of the immune system, because we don't want immune system to be always on a hyperactive mode to be active and potentially attacking in non-specifically. So when we use checkpoint inhibitors, this is specifically to help activate our immune system to be able to attack cancer cells. So the next type is called chimeric antigen receptor or CAR-T cell therapy. And what happens is that patients' own T cells have been genetically engineered to produce an artificial T cell receptor for the use of immunotherapy. Then these activated T cells given back to the patient, and now they're able to identify, attach to, and kill the cancer cell. Other types of immunotherapy called cytokines, and these are naturally occurring molecules of our body and important for cell signaling. The cytokines, when used as a treatment, then these are small proteins that carry messages between the cells. So we can provide, in a way, those proteins that will eventually create and send those messages to our immune system to be able to stimulate and send the signal to fight the cancer. What are the types? So there are several types of monoclonal antibodies. And you may or may not have heard very difficult to pronounce names for our drugs, and they're actually a special nomenclature that they use related to the origin of these molecules. So, for example, if the antibody is made from a mouse protein, it would be ending on OMAB. So one such drug is called Tositumomab, and this is an anti-CD20 targeted therapy and used for non-Hodgkin lymphoma. Another type is called chimeric, and this would be a combination of a part of a mouse protein and a part of a human protein to put together in one antibody. And the name of it would be then ending on Ximab. So, for example, rituximab is one of the monoclonal antibodies, which is anti-CD20 chimeric type with for patients with non-Hodgkin lymphoma and CLL. Another type of chimeric monoclonal antibody would be brentuximab vedotin. It's actually an antibody conjugate. And I'll mention it a little bit later in our presentation. This particular target is anti-CD30, and this is basically a molecule on cancer cells called Hodgkin lymphoma cells. So this is a very effective treatment that we have right now for patients with Hodgkin lymphoma. Another type is called humanized, and humanized, it's basically an antibody that has human antibodies and contains some parts of mouse, and they end on Zumab. And other types of medication would be alemtuzumab, for example, for B-cell CLL with a target to CD52. Gemtuzumab oganomycin is anti-CD33 for patients with acute myelocytic leukemia. And another humanized antibody is polytusomap. So all of these are important treatments for hematologic malignancies that I will be touching base because they have unique function. And Another type I would want to mention is human, and human is basically genetically engineered mice are able to produce human types of proteins, antibodies, and they're ending on umab, such as Tositumomab. And why is this important? Well, when you have a less differences between the foreign molecules being introduced or medicines or the drugs, you have less and less potential reactions. And this is why the similarity to the human type of antibody would be important. All right, so how about types of hematologic malignancies? What are the types of hematologic malignancies that we utilize monoclonal antibodies for? And here I am only listing some of them, and specifically in relations to anti-CD20 molecules and anti-CD19. And what this picture shows is that we have B cell development, and this is our normal cell generation coming from your bone marrow, from hematopoietic stem cell, and they're initially expressing CD34. As the cell matures, it becomes pro-B cell, then pre-B cell, and then the markers on the top, on outside of the cell change as well. Eventually, the cell starts developing markers that are called CD19 and CD20 on outside of the cell surface. And this is present on pre-B cell, which is important for precursor B cell leukemia if the cell becomes cancerous. Immature B cells, such as acute lymphoblastic leukemia, if a normal cell turns into leukemia type, and also present on mature cells, such as for example, if becomes malignant, would be B cell lymphoma, such as non-Hodgkin B cell lymphoma, or chronic lymphocytic leukemia. Patients that have a plasma cell dyscrasia, so basically a generation of a normal plasma cell going into a cancerous cell, that would be called a multiple myeloma. At that point, they already lose the CD20 target. So medicines that would be anti-CD20 would not be effective in this particular disease. So for anti-CD20, we have actually several monoclonal antibodies, and one most readily used is called rituximab. It's one of the older monoclonal antibodies. There are some differences between them, and that relates to what type of reaction they potentially have against the cancer. Do they have direct killing? Do they use complement or other types of processes or pathways? And they have some differences, and but they are all targeting CD20 positive hematologic malignancy cells, such as in Hodgkin lymphoma and B cell leukemias. So what is the mechanism of action for rituximab, for example? So one portion of the antibody called FC, what it does is that it instigates an antibody-dependent cellular cytotoxicity. Another way that it also can induce cancer cell killing is by increasing complement-dependent cytotoxicity. There is also a direct killing by a different immune cell, a good cell called NK cell, and that's also the way this particular monoclonal antibody is being recognized by our immune system. What we have is that it's currently approved for multiple types of lymphomas, because within non-Hodgkin lymphoma, we have many types. Some are indolent and some are more aggressive, but almost all express CD20, and we can use this medicine for our patients. So what is the advance then? What was the hematologic improvement? So in the past, when we did not have this monoclonal antibody, we used a combination of chemotherapy called CHOP. And that was standard of care for many years until we developed or medical community developed rituximab. And what the study did is that they looked at patients with advanced diffuse large B-cell lymphoma, advanced stage. Patients were also older, and they compared rituximab CHOP to CHOP. And what we can see is that there was a significant improvement of progression-free survival and also overall survival, with median PFS of 1.2 years for CHOP versus 4.8 years in R-CHOP. And median overall survival was 3.5 years in CHOP group versus 8.4 in R-CHOP. So from then on, this became a standard of care for patients with diffuse large B-cell lymphoma or patients that have CD20 positive disease. So another type of monoclonal antibody, very new, is called Tafacetamide. And Tafacetamide is a humanized anti-CD19 monoclonal antibody. So now we're using a little different target, which is a CD19, also present on B cells, with similar type of actions, direct cell death, ADCC, in this particular study, they combined another immunomodulatory drug called lenalidomide. And this medicine can also increase the activity of T and NK cells and also help with direct cell death. So in this study called L-MIND, they combined the two medicines, tafacetamide and lenalidomide, and patients who responded, they continued this tafacetamide maintenance for additional year until patients developed progression, for example. And what they looked at is basic characteristics for patients, and most patients were with high risk disease. They had elevated inflammatory markers, and they also had refractoriness to prior chemotherapy. So high risk population. Side effect profile was related to infection and immunosuppression, and efficacy showed that overall response rate was 60% in this study, with CR rates achieving 42% in this combination. So I would like to now discuss the next type of monoclonal antibody called conjugated monoclonal antibody that I briefly mentioned earlier. So brentuximab is an antibody drug conjugate that targets CD30 antigen, which is attached to monomethyl auristatin E, MMAE. And that is a microtubule inhibitor. It's almost like a chemotherapy attached to a monoclonal antibody. Another type that we have that I'm going to go into a little bit more detail is called Polytusomaphytotin, and this is another antibody drug conjugate that targets CD79 and similarly delivers MMAE. So mechanism of action for these types of drugs is that when this antibody drug conjugate is internalized, first it attaches to cancer cell, then it becomes incorporated or internalized by the cancer cell, and then it's being transported to lysosome in the cell where the linker that connects the chemotherapy to the antibodies being cleaved. So what happens is that MMAE binds to the tubulin within the cells and causes arrest in the cell cycle, and that leads to cell death. So basically, it's almost a targeted specific because it uses specific CD markers only on cancer cells, delivering the chemotherapy directly in the cancer. And this is a representation of polytusomaphytotin and how it works attached to the cell, comes into the cell, and then breaks up the building blocks of the cell. So the study was conducted again in diffuse large B-cell lymphoma, and looking at single agent, the response was overall response 51%. When they combined it with rituximab, which we just learned about, with a CD20 target, the response was similar, 56%. So then the next study, randomized study, was conducted looking at polytusomab combining with a standard of care chemotherapy, which includes bendamustine and rituximab. So bendamustine and rituximab, again, has been used for a long time. And now we're introducing polytusomab, which is a CD79 conjugated monoclonal antibody to drug conjugate. And what we're seeing here is actually responses to the combination versus BR alone. And you can see that polytusomab with BR is doing significantly better. So the efficacy shows that median PFS was about 2 months for patients on standard arm with bendamustine and rituximab versus 7.5 months median. Okay, so that was between 4.9 to 17 months that patients had progression-free survival, and overall survival similarly was better in polytusomab bendamustine rituximab group with 12.4 months versus 4.7 months. So that's pretty significant. And again, changing standard treatment changing procedures now. So this is a duration of response that patients continue to have a response. Now we're moving on to checkpoint inhibitors. So checkpoint inhibitors called PD-1 inhibitors, such as pembrolizumab or nivolumab. And in hematologic malignancies, these would be used for treatment of Hodgkin lymphoma patients. As Hodgkin lymphoma patients are a little bit unique, where they respond to this particular inhibitors as opposed to, for example, other hematologic malignancies that are maybe not as susceptible. And another group is called CTLA-4. And that uses, and the type of treatment is ipilimumab, for example. It's a monoclonal antibody that attaches to CTLA-4 marker, blocking the off-switch effect on the T cell. So we're taking off almost the brakes. And this helps boost immune system against cancer cells. Ipilimumab is used actually in multiple myeloma or solid malignancies over hematologic malignancies, but there's studies ongoing for Hodgkin lymphoma where that's being combined with something like pembrolizumab. And as I said before, checkpoint inhibitors basically take off the brakes off of T cells. So now T cells become active to go against cancer. And this is a representation of how CTLA-4 antibody, for example, or PD-1 antibody would interact with a T cell and a cancer cell, and how there is suppression of negative regulation and inhibition signaling also being disrupted by introduction of these particular antibodies. So next type of monoclonal antibodies called bispecific monoclonal antibodies, or sometimes they call bispecific T cell engagers. And what it does is that this type of antibody enables a patient T cell to recognize malignant cell. So what we have now is a normal T cell basically surveying the body for any foreign organisms or cancerous cells, but may or may not be able to recognize it. When there is a presence of this particular bispecific T cell engager, it has a target, a dual target. It's a bispecific, right? So it's specific to a target on the T cell called CD3, and it's also specific to a different target on B cell malignancy. So one of them is CD19, and that particular bite would be blinatumomab, which is used for ALL, leukemia, and another one is currently in clinical trials with a target of CD20 on B cells, and the other target is CD3 on T cells, and it's now called mosunetuzumab, and this is for patients with non-Hodgkin lymphoma. So this is the representation of how blinatumomab is, for example, made, or bispecific antibody. There would be in a way similar. So the monoclonal antibody to CD3, right? CD3 is on T cells, and monoclonal antibody to the target, and it's represented in pink. This particular pink portion is taken and combined with a blue portion, which is a specific target to CD19. So you basically have a combination of only parts, but they're targeted parts, they're bispecific parts. So the pink part is attached to the T cell on the top, and the blue part is attached to the cancerous leukemia B cell to CD19. And what happens now is that this the T cell that was basically surveying the body now is directly attached to the cancerous cell. And this is where the activation signal begins, promoting, first of all, T cell expansion, and then further signals the B cell or leukemia cell destruction. So this is bringing immunotherapy directly in close proximity to the cancer cell. So Mosunetuzumab is another bispecific monoclonal antibody to CD20 and CD3, and it simultaneously binds to the two targets. And during this period, it activates the T cells, very similar to Blinatumomab. And what initial studies have shown is that overall response rate was 62%, and remission rates were seen in 43% of patients with low-grade lymphoma. Low-grade non-Hodgkin lymphoma would be a lymphoma such as marginal zone lymphoma, follicular lymphoma, and these are low-grade types. And aggressive types would be something that is mantle cell lymphoma, for example, or diffuse large B-cell lymphoma, double hit and triple hit lymphomas. Those are more aggressive types of lymphomas. And in this study, they show that overall response rate was 37%, and remissions were about 19%. They also looked at patients who received CAR T-cell therapy. We're going to look at that. So patients that receive CAR T-cell therapy, they undergo a lot of other therapies before they get to CAR T. And that means the patients have quite highly difficult disease to treat. They're resistant to a lot of therapies. And what we saw is that patients that progressed even after CAR T-cell therapy, they received this particular bispecific antibody and still had responses. They had overall response of 43.8, and CR rates were still seen in 25% of patients. What are the side effects of monoclonal antibodies? Well, infusion reactions can happen. Something like serum sickness or flu-like symptoms can happen because, again, it's a monoclonal antibody. And fevers and chills and weakness have been reported. More severe cases can be where patients have low blood pressure and maybe difficulty breathing and low oxygens, but we usually pre-medicate our patients to prevent any of these side effects. So now I would like to talk about chimeric antigen receptor T-cell therapy. And this is now also called immunofactor cell therapy. And the reason is we are looking into cells that are not only T cells that also can provide the immune effect against cancer. So what we're seeing on this particular cartoon is that these are components of CAR, and they're basically antibodies that are linked to a hinge and transmembrane domain. So over time, we have different CAR-Ts developed, but the basic pretty much stayed the same. But what happened is that co-stimulatory domains were added to ensure that better and stronger signal is now being produced with next generation CAR-T. So these are CD19 CAR T products in pivotal trials that we've had for diffuse large B-cell lymphoma. Again, they're using a basic structure of CD19 antibody, also hinge protein, transmembrane protein, signal 2, signal 1, and gene transfer. But of course, there are differences in between each of these particular products where hinge or transmembrane protein is different, signal maybe is different, or gene transfer is different. And these are some of the products that we have that include axi-cel, tisa-cel, and lyso-cel for patients with diffuse large B-cell lymphoma. So what is the workflow for T-cell production? So first we have to collect patients' T cells, and this is almost like a blood donation. Then the T cell has to undergo processing. That time takes that process takes time, and it could be from 17 days to maybe 30 days. Depends on manufacturing. And what happens is that the cells are being transduced with a virus and make sure that they're able to express the proper target to be able to recognize the cancerous cell. Once the product is ready, the patient receives lymphodepleting chemotherapy because these T cells are active, and we need to make sure that patient is prepared. It's called lymphodepletion, prepared to receive the activated T cells because they're immunologic. And the infusion happens, patients receive the T cells, and then we observe our patients for a recovery process. ZUMA-1 was one of the first studies looking at CD19 CAR T for axi-cel, and they looked at patients that had a refractory diffuse large B-cell lymphoma or primary mediastinal or transformed follicular lymphoma. Patients received axi-cel 2 × 10⁶ CAR positive cells per kilogram per patient. Most patients were able to enroll successfully and manufacture the product and receive their products. What they found is that medium follow-up in phase 2 was 8.7 months. The updated analysis for 108 patients was median follow-up 15.4 months. What they saw is that for the phase 2 primary analysis, best objective response was 82% with CR of 54, with ongoing responses of 44 ORR and CR in 39%. When they looked at the updated analysis, they noticed that it was pretty similar. And with a longer follow-up, they still see overall response rate of 82% and remissions of 58, and ongoing responses remained very similar. This is the duration of response. What they see is that in green, patients that had remission continued to stay in remission. But patients who had a partial remission, they had a little bit worse duration of response. Similarly, they looked at 27 months now. Looking at median PFS, it was about 5.9 months at that time. Adverse events included CRS, neurologic toxicity, and also looking at grade 5, which means death due to therapy. Most patients developed low globulin levels and B-cell aplasia because it does target B cells. Grade 3 adverse events were about 95%, and similar 97% in updated analysis. CRS specifically was about 13%, and neurologic toxicity was about 28 to 31%. What they did is that they looked at patients who were in remission at day 30 and say, well, what happens by day 90? Patients that were in remission by day 30, which is CR, stayed in remission at 81% by day 90. Those that had partial remission, by day 30, they actually converted to full remission by day 90. So what we do as a part of standard of care is that patients that receive their CAR T-cell therapy, we evaluate that with a PET scan a month after CAR T. And again, reevaluate by 3 months, because patients that had some response, they might go into full remission by 3 months. And this is what we're looking for. This is just a chart stating that what were the features associated with remission going at 3 months. Interestingly, they felt that female gender maybe would be more a positive factor, better performance status, patients that relapsed versus patients that never responded to chemotherapy, called primary refractory. Patients that had less bulky disease might have more favorable outcome, and patients that met eligibility for ZUMA-1 study or not, because there was a question that it might have been strict criteria to be enrolled on that study early on. So what are the toxicities for CAR T? They're very unique, actually. And one of them is called cytokine release syndrome, or CRS. And this is inflammatory syndrome where cytokines are elevated. Patients can have fevers, high heart rate, low blood pressure, low oxygen. They can get very sick. And another toxicity is called immune effector cell associated neurotoxicity, or we call it ICANS short. And this is when patient can get confused. Patient might have headaches, tremors, can also have seizures or potentially coma. So these are not easy treatments, but we learn how to recognize these side effects and treat them immediately to prevent for worsening of the symptom and reverse toxicity quickly. These toxicities are related to cytokines such as IL-6, for example, and one type of medicine that we use to reverse these side effects of CRS called Tositumomab, which is an IL-6 inhibitor. So this again shows CAR T-cell adverse events and which patients had, including CRS grade 3 and higher, or neurologic toxicity. Some patients did die, and what they reported is that one was with a high hyperactive immune syndrome called HLH. Heart attack was reported, and pulmonary embolism as well. So FDA approved CAR T-cell therapy includes several actually products right now, which we're really excited about. Acute lymphoblastic leukemia has 2 products, CISA-cel and Brixacel. Diffuse large B-cell lymphoma has 3 products right now, Axis-cel, with most recent FDA approval for second line, which is very excited, came just a few days ago, and other CAR Ts. Follicular lymphoma now has an indication for CAR T-cell therapy, mantle cell as well, and also exciting, multiple myeloma has 2 products right now. As you can see, it's very early, very recent approvals that we have, starting in 2017. And this is very recent type of therapy that we have, and we're excited to be able to offer this part of standard of care for our patients with heme malignancies. So this is the approval that just came recently, a few days ago, basically letting everyone know that Axis-cel, another commercial name is Yescarta. So Axis-cel is now approved as a second-line therapy. And what CAR T-cells are approved for now is actually third line. So that means patient has to progress on 2 types of chemotherapy before they can be offered CAR T. But this particular approval now is allowing our patients to bring this treatment much closer to early relapses, so we don't have to put patient through more and more therapies until we get to effective treatment. And if you are able to see the graph, and I apologize if it's too small, but what the graph shows, the randomized clinical trial, what they did is that they looked at patients that would need to go on standard of care, which is stem cell transplant in first remission for diffuse large B-cell lymphoma, or they took these patients to CAR-T-cell therapy. And CAR-T-cell therapy is depicted in the yellow line, and that shows superiority over standard of care for patients, and showing remissions and basically event-free survival on this graph. So for acute lymphoblastic leukemia or patients with B-cell ALL refractory in second or later relapse, we have right now one of the treatments with CAR-T is Tisa-cel, and this is a CD19 CAR. This slide shows the real-world experience from the CIMBTR registry. And what it shows is that patients that at 3 months, they developed 81% went into remission, which is quite incredible. So future directions, what are we focusing on and in immunotherapy? And of course, that would be improving immunotherapy in general, improving potentially side effects, improving outcomes, improving efficacy. Similar for CAR T-cell therapy, we want to make sure that T-cells persist and their activity is also targeted specifically. Looking at things such as dual CAR-T, meaning they have a couple of targets with one T-cell. Also looking at reducing side effects, any additional drug combinations or changes within the T-cell, and this is where the research is focused right now. Also exciting in the field is that now CAR T-cell therapy is being developed for solid tumors, and we see patients on clinical trials getting treatments for different solid malignancies, and this is quite exciting actually. So this is a small cartoon showing that patients that might be having poor responses, maybe they have PD-1 inhibition, and maybe changing certain things might improve CAR T-cell efficacy, and also doing something like a dual CAR-T that has different targets, maybe CD19 and CD20, but using CAR-T instead is something that's being in the works. So this brings us to the conclusion of my presentation, and if you have any questions, I'll be more than happy to answer them.